Hello, my name is Christy Hughes. I'm a student with the University of Kentucky in their Medical Laboratory Science program, and I'm going to be presenting a case study today on pediatric brucellosis. This is going to be in a three-part submission. Our first abstract here is brucellosis is a zoonotic infection that occurs readily worldwide, but it's rarely seen in primary care in the United States, with only 100 to 200 confirmed cases per year. Brucellosis infection is caused by the bacterial genus Brucella. This disease has been known by various names, including Mediterranean fever, Malta fever, gastric remittent fever, and undulant fever. Humans are accidental hosts, but brucellosis continues to be a major public health concern worldwide, and it is the most common zoonotic infection. History and present illness of our patient. The patient and his family had recently visited his mother's uncle, who lived on a small farm on the Texas side of the U.S.-Mexico border. The family had stayed with the uncle for 2 weeks. He had been allowed to play with the animals but had not been exposed to any births, which the cattle herd there at the farm had recently given birth to quite a few new calves, and he had also not been exposed to any slaughtering of livestock. His family had returned home the same day that his symptoms began, and the child had been sick for 3 days now. The mother stated that the child hadn't been in contact with anyone that had been ill. She also denied any recent consumption of unpasteurized dairy products or undercooked meat by the child or any member of their family. The child was up to date on all immunizations, including influenza, and had not received any recent vaccinations. He also had no significant medical history except for seasonal allergies, which were treated with Zyrtec as needed. The mother denied any use of illicit drugs, smoking, or alcohol abuse in their home. His physical examination, the mother had stated that the patient was on ibuprofen and acetaminophen as needed for his pain and fever, but today his positive findings were that he exhibited clear rhinorrhea. He had hypertrophied tonsils with exudate, a non-productive cough and temperature of 100.2 degrees Fahrenheit. The patient also complained of bilateral leg pain. The mother also stated that the patient hadn't been eating well. Some negative findings on the physical exam were that the patient had lack of palpable lymph nodes and his lungs were clear. This is just a picture of the grading of the tonsils. His tonsils were a 2+, which is the middle picture there. The differential diagnosis. Based on the history and physical examination, the initial suspects included some of the more minor ones here: viral upper respiratory infection, rhinovirus and RSV, strep throat, influenza, mononucleosis, and some of the more major suspects would have been tularemia, salmonella, and brucellosis. The treatment plan for this individual. Surprisingly, there was no testing performed on the initial visit. The patient had no vomiting, diarrhea, or bloody stool. So based on his presentation of mild distress, and outside of the viral treatment window, the nurse practitioner diagnosed him with a viral upper respiratory infection and discharged him. She instructed the mother to continue treatment of acetaminophen and ibuprofen as needed to treat the pain and fever. She was instructed to push fluids to help to prevent dehydration, and the mother was also instructed to follow up in 7 to 10 days or to bring the child in sooner if his fever got worse or persisted. And this sooner if the fever persisted or got worse. We're going to move on into 2 days later. The mother brings her 4-year-old boy back into the clinic, and the child is getting worse. He still has the persistent fever. He has more body aches. The mother states that her son is worse than before, and she's very concerned. This time, the child presents with a fever of 104 degrees Fahrenheit. However, physically, the boy still looks the same. He has no skin rashes or marks when evaluated. The physician that's seeing the boy this time admits him into the hospital, and he orders some blood work, including a blood culture and a febrile agglutination panel because of recent travel to the Mexican border area and likelihood that the patient had been exposed to brucellosis. He also ordered a chest x-ray. Now we're going to move into some of the test results. The chest x-ray was normal. The CBC revealed a slightly elevated white blood cell count. The liver enzymes were elevated. Brucellosis is a systemic infection, which means once that the bacteria is ingested or has made it into the body, it spreads out systemically and it affects various parts of the body. The blood culture was positive. This was ran with a BACTEC, which is some of the quicker instrumentation available. However, the blood culture still would have taken a couple of days to be positive. And the serology, which is the quickest identifier available in this situation, the febrile agglutination test with indirect assay for Brucella abortus was positive for IgM and IgG. The picture here, I know you can't see it very well. It's some test tubes. I can try to move this a little closer to make it more clear. And I know I'm shaky here. Let me try to get it positioned well enough. There we go. The febrile agglutination test is testing for these antibodies that cause the red blood cells to clump together here. Febrile, meaning that they're warm antibodies that function at a normal body temperature. The IgM, which is indicative of recent infection, and IgG, where the body has started to respond and is making its own antibodies against this bacteria. And you can see this is just a titering and grading on the top of a negative. These are negative, no clumping there. Positive result, which is it's starting smaller clumps to a 1+, a 2+, and a 3+ agglutination. The titers here 1 to 20, 40, so you'd have like a 160 titer here is where it ended up being. So I'm going to back that back up here, and we are going to go on to our next slide. A positive blood culture identification. Brucella was suspected and confirmed with the febrile agglutination panel, so the laboratory already knew that it was dealing with a very unsafe bacteria. Brucellosis is a CDC bioterrorism Category B agent, and since it was suspected and subsequently ID'd by the serology, the lab performed a workup under BSL-2 and BSL-3 conditions, which is biosafety level 2 with a biosafety level 3 practice. This is just for additional safety when performing lab research with certain higher risk biological agents in a biosafety level 2 laboratory. This would probably include a rear opening lab coat, double gloves, goggles, a face shield, and any open manipulation of the organism. The infectious agent must be conducted inside a biological safety cabinet or other physical containment device. And the gram stain, you can see, revealed tiny gram-negative cocobacilli, some retaining crystal violet, a colony morphology on blood agar and chocolate. that was non-hemolytic, non-pigmented, small gray colonies at 48 to 72 hours. We already mentioned prior that Brucella is a slower growing organism, and they grew it in a 5 to 10% CO2 environment. And biochemically, this was urease positive, oxidase positive, and non-motile organism. This is the end of our second. So we're going to move on into looking at the chemical reactions that Brucella has. The top one here is the urease positive reaction. Hydrolysis of urea produces ammonia and CO2. The formation of ammonia alkalinizes the medium, and there's a pH shift, which is detected by a color change, a phenol red, and it goes from this light orange, which it kind of looks more yellow here, but it goes from this light orange, which has a more acidic pH of 6.8, to this magenta pink, and this is more of a pH of 8.1. So it went to a more alkaline pH here. And then the bottom picture here is the oxidase reaction. Brucella is oxidase positive, and organisms which contain cytochrome C as part of their respiratory chain are oxidase positive, and they turn the reagent a blue-purple color. You can't hardly see here. I'm going to move the camera again to more. Now you can see that there is like a yellow spot there, and that the reaction is taking it to a positive with that purplish color. So I'll move our camera back, and let's go to our next slide. The final diagnosis. Based on these findings, the patient was given a diagnosis of recent infection of brucellosis. Now this top picture here, I just kind of put in there. Of course, the child didn't come into contact with pigs. The farm was more of a cattle and goat farm. But for all intents and purposes, Brucella species are gram-negative rods that do not have a capsule. And they're ingested by polymorphonuclear cells and macrophages once in the body. And then they're passed to the lymph node. The organisms replicate intracellularly, and the bacteria from these last cells can then infect other cells within the body. That's where you're getting your systemic infection with Brucella. They have many survival mechanisms to suppress the host's immune response and to avoid destruction. They can withstand bactericidal substances and elude the action of macrophages. And without appropriate treatment, brucellosis can launch an immune process within a host that promotes a chronic infection. So the mother, of course, needs to understand this. So how did my child get this? When explaining to the mother what was going on with her son, the practitioner explained that he had probably come into contact with the bacteria at the farm and had come into contact with either animal urine or some of the byproducts of the births that had happened at the farm. He also explained that this was something that could have had a chronic, and if not correctly and promptly treated, it could have had fatal consequences as well to her son. And he advised her to contact her uncle, and that they would be contacting him as well, probably, because they would have to report this to the health department. Treatment. The patient was given trimethoprim, sulfamethoxazole, and rifampin for 4 to 6 weeks. The mother was encouraged to bring the child back in after treatment for a follow-up, and she should bring him back sooner if he didn't get any better or showed signs of getting worse for some reason. What can the uncle do about his livestock? Well, this didn't end with the child. The livestock and the people that are around the livestock could be exposed to this as well. So the first step would be to quarantine the livestock until they can be tested for brucellosis. And the second step would be to contact the veterinarian and health department to get help to eradicate the disease from the herd and to keep this from spreading to other animals and other humans, most importantly. The third step, there is vaccination for livestock so they don't contract this and spread it. Here's some works that were cited. And I thank you so much. I'm going to turn the camera and say hello. Hopefully I'm getting a good shot. But I'm Christy Hughes, a student at the University of Kentucky, and thank you so much for watching my case study.